We'll go live to Apollo Hospital, Hyderabad, for a quick update of what's happening. Dr. Rath, we are over to you.
Actually, this is a very simple case, but then we thought we landed a patient had severe hypertension. We managed it. I'll ask with me Dr. Manoj and Dr. Basra Kiran is there. I'll ask Dr. Basra Kiran to present the case. Yes, sir.
Yeah, hi. Good afternoon, everyone. Can I have the slides on, please? Hi. So the fifth case from Apollo Hyderabad, we have a 73-year-old lady who's a hypertensive and diabetic with normal coronaries. She presented to us with class 3 dyspnea for the past 1 year. ECG shows sinus rhythm, no bundle branch block, but echo, we find some LV dysfunction with an ejection fraction of 45%. And she's got a severe aortic stenosis with a max gradient of 77 and a mean of 45. Her STS score is 3.28. And this is the ECG showing sinus rhythm and a narrow QRS. And echo showing max gradient of around 70-75 and a mean of 45. So the basic investigations were essentially normal. The creatinine is 0.73, HB is 13.
See, this patient, after we crossed to LV, she had hypertension. We checked the pericardium, that was normal. We checked the groin, that was normal. Then we went ahead, we thought it could be because of the tight aortic stenosis. We ballooned it. After that, BP improved. BP was now 95 to 100. But we checked the echo again. There is pericardial effusion. I think we have to drain it before we proceed for anything. What we have done is, we have put the, we'll put the device now, and after that we drain it.
Then after that we can reverse the heparin. I'm going to compress the artery.
Yeah. We'll go ahead and...
Yes.
Okay.
Give me some gauze here, please.
Dr. Purohit here. Can you tell us which wire you took, the stiff wire? Is it a Safari or Confida? Which wire is this?
This all happened before we took the stiff. We took a
wire.
It all happened before after we crossed the LV, patient had hypertension. And this is later on the BP came up, we took the Confida wire again.
17.
And that time it was, I think it happened during the crossing.
So you think probably the straight tip of the wire just went deep inside and perforated?
Yes.
Could be.
Hello? Hello? Go. Good. 15, 17. Come back. Okay. That's okay. Okay. Get the injection. 15, 17, brother. Sir, pichhe le. Caudal 15. RAO. Caudal 15.
So which valve you have taken?
Inject. We have taken 26. 26 Medtronic.
10 ml, 10. Yeah. Go ahead, sir. Cine.
Just take.
Okay.
I think that's okay. I would come up with that.
Yes.
Okay.
Just to start. Yeah, perfect. Okay. Very good.
Okay. Just show the fluoro. Just show the last injection once. Sorry, one fluoro. Last injection, show us.
Show the injection. Okay, show the last injection.
Before this? Okay. Pigtail is finally placed. Okay.
Okay, you want to, pacing.
No, not now. BP is already low. Nothing is required.
So let's start. Yeah. So we have started to deploy the valve.
Push the wire. Okay.
Go a bit below. Yeah, push it a bit.
Yeah.
Please.
That's
perfect.
Little bit up.
So the reason why we decided to deploy the valve is that the blood pressure is pretty good now. So the patient hemodynamically is in a
Okay.
kind of okay condition.
That's
So we
okay.
put the valve,
So,
we drain the
injection.
pericardium,
Inject.
Finish.
and of course we reverse the heparin after that.
I think it's okay.
Yes, let's go to LAO. So we are going to LAO.
Go to the RAO.
Hello.
LAO. So we
LAO.
are
Yeah.
we are approximately like 4 millimeters below the
Okay.
pigtail, so below the non-coronary cusp. So we are checking out the depth below the left coronary cusp now.
Yes. Inject.
A bit more LAO.
More hello.
Okay.
Okay, inject. Inject.
It's too deep.
I think that's fine. Let's just
That's
just
fine.
put it down because we have to drain the pericardium.
Shall I?
I think it's
Yeah.
good. Yeah. So we are putting it. It will tilt anyway.
I'm going slow.
That's good. So the pressure is relieved. Very good.
Okay.
Okay. Perfect. Perfect. See, the valve tilted a bit.
Yeah, I know.
So I think it's going to be a very good depth.
That's good. Pull the wire towards you. That's okay. That's okay. Thank you. Yeah. Yeah. Now pericarditis
So please
synthesis.
check out the pericardium again.
Then the BP is around 70. How much the BP? 60.
Okay.
70.
Give
BP
fluid.
is
Give
60
fluid. Lots
with
of
the
fluid.
Okay. So what we can do?
If you deploy fast, also valve will come up.
Okay.
We had a lot of implant depth. More
So
than
the pigtail is still in a jailed position. So
Yeah, we'll
please
take-
pull out. Yes. On a wire.
Okay.
Yes. So we gotta drain the pericardium. So
We have to drain the pericardium. Pericardial effusion is increasing.
yes.
Pericardial
So we
synthesis.
go and drain. Bassa.
Sir, we can reverse the heparin if you want.
Yes. I
reverse
think we
the heparin,
should,
go
but
and drain.
we need to pull the wire out of the LV.
Yes, I will do it.
And then after the drainage, we can decide what to do, whether we need to do anything else with the valve.
Okay. So you want to take out the wire?
One minute.
Yes.
I'll just take out the
That's
pigtail.
in a jailed position.
Yeah.
And please prepare for the pericardium, for the drainage.
Sister, you can't give me this kind of wire. Okay, give me another pigtail, sister.
I think this is not an ideal.
Okay.
Can we do it from below? This is probably better, right?
Sister pigtail.
Yeah.
Before that, we'll require a sheath.
Give the needle.
One injection.
How much the BP?
Show me.
80.
Oh, 80, that's
Show me.
fine.
Okay.
So we're safe. So what we,
This parallax is okay.
yes.
We'll finish this. Okay, ready?
Yeah. Let's do that.
Okay. I need kuch.
Kya, what do you want?
We finish the injection.
Okay.
Good.
Okay. You want to give an injection?
Yeah.
Okay.
Take it.
Okay. Ready?
Big sheath, sister. Connected nahi hai? 1 minute. लो. Disconnected. Sister सीट दे दो फटाफट 14 पे. ये आ जाओ. सर आप इसको पकड़ोगे मैं नेक्स्ट सीट निकाल. Sir, hold it, sir.
You want to take out everything?
Yeah. No, we'll put the sheath, put a pigtail, and then take out the wire.
Okay.
Good. Okay, so we are going back with the 14 French sheet. Then we are going to put a pigtail into the LV. And in the meantime, we are preparing for the pericardium drainage.
Give fluid, na, senior. Some crystalloid, अच्छा. Protamine दे दो protamine, थोड़ा दे दो protamine, 25 दे दो. And we take an ACT in the mean. Give me a pigtail.
Okay.
ACT and 25 units protamine you give, then we'll see.
Let me just flash it for you because I
Yeah.
don't know whether it was flashed or not.
Please.
Yeah.
We can't put it in LV like that.
Yeah.
Yeah. Yeah, flash.
Doesn't matter. No. That's not- We're gonna flash it after that anyway. So
Good
you
afternoon,
better
Dr.
speed
Rath.
up.
Yeah.
Doctor, very nice to see Dr.
Okay,
Peter
moving to
Andreka.
wire.
Good afternoon, sir.
Yeah.
Hi,
If
hi,
you give
good
protamine,
afternoon.
we have one doubt. If you give a
I'm
protamine,
sorry, we are working very fast. Yes, we are doing it.
are you able to hear?
Okay. Yes, I can hear you.
Sir, very nice to see you, sir.
So-
How much?
If you give protamine, sometimes
100.
it may clot. So sometimes it's very
LV.
difficult to evacuate. So it's very
Where?
ideal. If there is a tamponade features are there, better to aspirate. Then if nothing is there, you can leave it. But if tamponade is there, if you
Aspirate,
give a
hello?
protamine, if it forms a clot, definitely it will not come out.
So the plan
compression-
is, yes,
Quickly
so the
ask
plan is, the plan is to get out of the LV very quickly.
Varsha,
And
Varsha.
then we are going to
Varsha.
get the protamine.
Varsha. Take out,
Yeah.
take out.
Yes.
Fine.
So now we can now we can give the protamine.
You give protamine and take it
Yeah.
out.
Can you show us
So
the
the
ECG?
protamine is going in,
Take it out. It's
and
not-
the
Yeah, ECGs, some ECG changes are there.
Yeah.
yeah, just do the puncture. Yeah. I don't know whether would you please show the echo to the audience? Is it possible?
We'll see.
So
There is
please.
evidence of pulses paradox is
Can I
also
see?
there on
Good.
tracing.
Yeah. But BP has picked up 100. Very nice.
Yeah.
Sir, fluid is not much.
Not much. So you
Huh?
gotta be careful. So.
Dr. Peter,
Yeah.
fluid is not much.
Well, not from here,
Yeah, with
but
the
this
so-
is,
so
probably
little
this is
amount
the
of
best
fluid, would you like
position
to
to
do the
access the
pericarditis
fluid.
With so little amount of fluid, would you like to do the pericarditis?
Yeah, Flora.
No. So the thing is that this is probably the best place.
You
Okay,
have-
that's good.
Yeah.
So add some contrast just
Is
in
it
case.
not pacing where which is
Varsha,
responsible?
Varsha, give some contrast.
I would give some contrast.
Okay.
Yeah, that's good. So so the thing is that this is the best point to access the effusion, the pericardial effusion. It is actually pretty much. Not from here, from another projection, but we cannot access the pericardium from that particular point.
Okay, Varsha, ready?
Yeah, so let's see where we are now.
I'll take a cine. It's okay.
Perfect. So
Take it
let's
off.
start it.
Once we take
Very
it
good.
out,
This is a very, very nice job. So as you can see that we have
Oat
the
five long way.
the micro sheet in the pericardium. It was actually a very nice puncture.
Did it well.
Oh yeah. So
Take this. And get a 6
of course we are able to maintain the
6-inch seat
pressure
and a 6
with
inch fixture.
fluid and
Yeah,
with
that's it.
norepinephrine.
You need a blade, no?
So we have antagonized the heparin already,
You. Sister.
and then
Soon.
while
You forget
while
about
we are working
Take a blade.
Take a.
on draining the pericardium, we can discuss the possible source of the pericardial
Blade,
effusion. So I'm just asking the panel, what do you think about that?
Blade. Local.
About the possibilities? Actually, we have two main possibilities. I think that the number one is the pacemaker lead and the wire, the
6
straight part of the wire when we entered the LV and touched the myocardium.
Kink is
So
there.
most likely the source is the pacemaker lead, but of course we don't know it now. What do you think
Take
about
the
that?
dilator. Take the dilator first.
So I'm the only one who can talk right now because the other team members are working.
Give this to give the traction.
Is it balloon tipped
It's
pacemaker?
not going.
Pacemaker
it's
is
a
in
balloon
It is a balloon tip pacemaker, yes. Yeah, sorry, I didn't hear the question. I'm sorry about that. Say it again, please.
It went.
The balloon tip.
It's a balloon tip pacemaker, so definitely balloon tip pacemaker.
Gamna.
But to be honest to you, the complication rate of the balloon tip pacemaker is the same. So it can still happen with a balloon tip pacemaker.
But balloon tipped pacemaker, the tamponade
One
less
here.
likely because it protects. But sometimes, if you deflate the balloon and that time if you push, it can cause the perforation. But it may be because the guide wire, straight wire going and penetrating, that could be the cause.
That's another possibility.
Yeah.
So of course I cannot tell you at the moment what the source of the effusion is.
You
It's not
fibrance it.
I think the color of the blood which is aspirated can tell us. If it is a dark color, then probably it's the RV.
Right. Well, yeah, we're
Or if
going
it
to
is
check it out. We're
bright
gonna
color,
check it out.
then
It
probably
might
it is
be-
the LV. So we can
Yeah.
know
It went, no?
with the color of blood whether it was a pacemaker induced or wire induced.
Okay.
Blank syringe.
20 cc दे दो जम.
Good.
Is fairly bright.
It's difficult to.
Okay. So that is the color. Can you see the color?
Okay, fine.
Yeah, BP has to pick up, no?
BP has to pick up, that's all.
Okay.
So what's the color, Dr. Peter?
This pick up.
Take-
I can.
Color
It
is red.
Is red. Give me the syringe.
Is it
and then you
dark
can-
red
you
or
can go
bright
with the
red? That's
picture
what.
if you wish.
Just
I can-
arterial
I
or
can-
a venous?
Bright red, bright red. Looks like arterial.
So that is the color, if you can see it.
It looks pretty dark from here, suggesting it could be TPI
Ah,
induced.
well, it's somewhere between between dark and not dark here, from here. So we don't know. We don't know. Well, I'm sorry.
Just can you check the.
But
You can
we're trying to be
auto-transfuse
very
the blood because
careful
lot of blood is coming.
with placing the wire, of course.
Both of them.
Yeah.
Yeah.
So
Can you get some blood?
so we can give the blood back.
Yeah.
You can
Well, we can do
auto-transfuse
that,
the same
yeah,
blood,
from the venous
maybe.
line. That's what we are doing. That's what we are doing. Yes, yes, yes. It's
So that after that we will do.
And one thing which I would be
Yeah.
fearful is
We can use
if we
the-
have
we can
reversed the
use the
protamine,
side
we
arm.
reverse the heparin, the large sheath is in.
Yeah, but that's the arterial shit. Be careful.
इसमें देना है.
That's the arterial. Use the venous.
Yeah, that's the vein.
Yeah, I'm sorry. Sorry. Yeah. Good. So we're doing the auto
The
transfusion.
BP has picked up after aspiration. I
Okay.
think we aspirated how much?
We are checking the echo again.
Actually, during
100
pericardial
ml
the
is
effusion,
fluid is definitely less.
many times we encounter.
It is
Sometimes when
definitely
you
less.
give the protamine, the sheath and catheter can, because the clot, it can close, it can seal. So whenever it is choked, automatically again recollection of the pericardial fluid will be there. That time you have to pass the wire and pull the catheter and flush it, and again fresh catheter has to be inserted. Otherwise, patient may develop gradual onset of tamponade again. So this
Yeah,
happens many
agree.
times when you give a
Agree.
protamine, particularly in a pericardial
I
tamponade.
agree. Yes. Yes, you are
How is your
you
feeling?
absolutely agree. However,
So the pressure now.
we always antagonize the
Now the
heparin if
ECG
there
is
is a
settling
pericardial
down.
effusion. But
BP
just- you
has
just gotta
come
be-
up. I think it has gone.
Yeah.
It's more than 110 now. I think we are giving auto transfusion.
One injection. One injection in the meantime. Okay?
So go further down with the picture.
Yeah?
Yeah.
Yeah.
A bit.
Yeah. Ready?
Okay.
You want me to go in?
Yes.
Okay.
That's good. That's
Okay.
good. That's good. So
15.
so while we are draining the pericardium, we are
Yeah,
checking
and
the
we-
paravalvular leak as well, because we haven't had a chance to do that.
Yeah, that's
So-
what is my worry.
The blood is still coming.
Yeah.
Uh-huh. Good. Perfect. The result is very good. So as you can see, there's no paravalvular leak. The coronaries are nicely open.
Check the BP.
BP is this.
Yeah. The
BP
BP is
is
very good.
one-third.
Really coming.
Do you have a...
Shall we do a LV angiogram?
I don't know what I would do. What I would do, I would go into the LV and then just go for a pullback, just to check out the gradient. Just, well,
Why?
we can't do anything else. I mean, you're training the pericardium.
No,
so
I think it's okay. We can check it in the echo.
we can.
Yeah, we'll check it in the echo. BP has come up. I think first thing is now to manage the pericardial effusion.
Yeah.
Now the aortic stenosis is taken care of, and the valve is well placed, no air. Coronaries are okay. ECG not much changes, and BP has come up. I think first thing we have to decide about the management of pericardial effusion. Now the aortic stenosis part is taken care.
What is
So
the ECT system?
I think
Abhi kam hua. Now it's
now
like-
that it's coming down the collection,
Shall we remove the
it
TPIV?
happened very fast. Patient had hypertension. We checked that time the echo. Absolutely, echo was normal. And then we checked the iliac and femoral side. We took angio, that was also normal. And then we went ahead and do the balloon. We thought probably because of the tight aortic stenosis, he's getting hypertension. After that,
Now it's
BP
okay.
came up, but again it came down. And after that time, when you check the echo, there was pericardial effusion, which was moderate. And I think aspiration helped him. We have to, it's coming, BP has come up now.
No more
BP
fluid is coming up.
130/80. And pericardial collection is also slowly, is almost, yeah.
It's
Now,
empty.
so the echo,
There. It's live echo there.
yeah, live echo you can see, pericardial effusion is gone, collection is gone, but we have to keep, we have kept the pigtail there, we have to keep aspirating. We have given protamine also, I think,
Heart block.
but I think we should first check that pacemaker side. I am very concerned about the pacemaker, probably that may be the cause, we have to see it. What do you want to do with the pacing lead? You want to,
We have to keep it. See, there is some heart block there.
I think echo is not showing any evidence of RARV compression. The both RARV is nicely filling
Yes.
and LLV is nicely filling. And there is no evidence of tamponade features. I think even fluoro and echo
Perfect,
definitely
perfect.
shows. Even pressures picked up very well. And really wonderful job.
but I
because
think the rhythm,
despite
rhythm is
perforation,
again, I think,
despite
I think
perforation,
we have to
implanted
keep
valve
the
and
temporary
managed
pacemaker
nicely.
because
So watchful waiting is the strategy, right, Dr. Rad, at the moment?
I think we'll keep aspirating.
Yes.
And if it flow stops, then probably we'll take out the pigtail catheter tomorrow.
Yeah.
And in the meantime, we have to keep a watch on the rhythm because in between the heart rate is coming down, rhythm is changing. So maybe because we put the graft little lower down, so maybe she may require a pacemaker later. But I
Yeah.
think first thing is to take care of the pericardial effusion.
Yeah, absolutely. Absolutely agree. And finally, let me congratulate to the team. They were extremely careful, and they were managing the problem very precisely. And as a last sentence, it was a minimally invasive procedure. We didn't use TE. The patient was consciously sedated, and we were trying to keep it as non-invasive as just possible. But we had an echo in the room just to check out the pericardium, and it's always mandatory to have an echo machine switched on in the room always when we do a TAVI procedure,
Check the issue.
because pericardial effusion can always happen. So congratulations to everybody.
Thank you very much. I think you will shift the patient and observe the patient for next 24 hours and see how the pericardial effusion is taken care of. Sometimes if persists, we may require surgical help. Because that also we have kept the surgeon informed, they are standby. But looks like his pericardial effusion has almost come down, there is no more collection now. no more, so I think it's taken care of. But we have to see, because may
Yeah.
again they will reappear in this. It's very pacemaker where I don't want to change the position now because the rhythm is changing. Sometimes if it is because of pacemaker lead, if you take out, then there will be again massive pericardial effusion.
Yes, I agree.
That is, we have to keep it in mind. So I think we have to observe this patient now, and we'll shift the patient to ICU and keep her under observation. In the meantime, we'll ask the surgeon also to surgical standby that patient may require surgery if the pericardial effusion reappear or doesn't come down again. I think we are going to shift the patient. I think you can go ahead for the other presentation of the other sessions. Thank you very much.
Thank you.
Just one suggestion from the panelists here, that if it is a pacemaker induced, then probably the threshold of pacemaker might have gone up. So that can indirectly tell whether the pacemaker has truly
I will
perforated, gone
check it.
beyond.
What is the pacemaker? Acha, you pulled it out? Acha, you came out, is
Yeah,
it?
it accidentally came out. It was an accident.
Okay, so, but we have to keep a pacemaker. We're going to keep one more pacemaker, isn't it? We are going to put another pacemaker where it came out accidentally, but the what about the pericardial effusion, any collection? There is no collection now. So, we don't know, maybe that is one of the possibility that is probably caused by pacemaker lead.
I think it can be an evidence.
I think it
for
was a
that.
great demonstration of
But, you know,
handling a
we-
complication, even during a live case. So many cool heads were there. I think that's the reason why the procedure could be completed so nicely and successfully without any event. And it was an excellent learning for all of us. So once again, congratulations to the whole team from here. And thank you very much, Dr. Rath and their team. I think you can continue managing the patient. Thank you.
Thank you.
Thank you.
But
I think we can go off live now.
so,
Thank you,
we need to take
chairpersons,
the
and thank you,
first volume
audience.
again.
You just had a demonstration
thank you.
of how to tackle an emergency during TAVR.